Welcome to today's webinar hosted by the California Maternal Quality Care Collaborative. Some initial and webinar information is being provided as we wait momentarily to begin. Thank you for joining us today for Improving Outcomes for Mothers and Newborns Affected by Opioids. The Maternal and Newborn Substance Exposure Initiative and its collaboratives are a joint project between the California Maternal and Perinatal Quality Care Collaboratives based at Stanford University and Health Management Associates. The objectives for today's webinar include: be familiar with the scope of the perinatal opioid epidemic and have a solid understanding of key concepts of quality improvement in the care of mothers and newborns affected by opioids. I am Christina Oldini, Associate Director of Programs at CMQCC and a clinical lead for the project. I am happy to introduce our panels of speakers today. Dr. Elliott Main, Medical Director of CMQCC and Clinical Professor of Obstetrics and Gynecology at Stanford University, will be presenting the current landscape and opportunity in California and emerging best practices in maternal care. Just the Facts, the Neurobiology of Addiction, and MAT, or Medication-Assisted Treatment, will be presented by Dr. Helen DuPlessis, Principal at Health Management Associates. And finally, Dr. Henry Lee, Chief Medical Officer of CPQCC and Associate Professor of Pediatrics at Stanford University, will present the emerging best practices in newborn care. Welcome to our three speakers, and Elliott, why don't you get us started?
Thank you very much, Christina, and I'm very happy to be here. We have an exciting program today. I'm going to kick us off talking about some of the background data overall for the opioid epidemic and where California fits in. If we could go to the next slide. This is one of the biggest public health epidemics that we have ever faced in the US. This shows drug overdose deaths per year compared to past epidemics that we've had, public health epidemics. Firearm homicides peaked in 1993. We surpassed that with overdose deaths somewhere around 2000. HIV peaked in 1995 at 43,000 deaths per year. Car crashes in 1972 with about 53,000 deaths per year. That was surpassed in 2015. 2017, we're way beyond, pushing to 70,000 annual deaths from opioid overdoses. Next slide. This is an article published last week in the Washington Post looking at data from the Drug Enforcement Agency as to where the opioid pills were prescribed and, more importantly, distributed. We're not talking about millions of pills here. We're talking about billions, with a B, billions of opioid pills in 6 years. That's an unbelievable number of opioids pills that have flooded America. And that's accounted for 100,000 deaths from 2006 to 2012. You can see that they were unevenly distributed, and that uneven distribution correlates very well with the places that had excessive deaths from opioid overdoses, centered in Appalachia, some in northern New England. You go out west, and it's largely in the west, in Nevada, New Mexico, in Northern California, and a little bit up in Washington State. But again, this is 2012, again, 5-6 years ago when this data was collected. Next slide. Starting on the right-hand side, The locations with high rates of prescribing opioids, as we just saw, also have high rates of opioid overdose deaths. And they also have high rates of opioid use in pregnancy, which in turn, of course, leads us to high rates of neonatal abstinence syndrome. When you look at states in the latest data up through 2017, and look at on the left-hand side of this figure, and compare 2013 and 2017 to see where the biggest rise has been. You can see West Virginia, Ohio, Pennsylvania at the top. And you can see all the way down at the bottom, it's California with the red arrow. We didn't change that much, except in a moment, we are going to show different parts of California, because California is one of the biggest states in the country geographically, and we have very strong regional differences. But leave it to say that we're not as impacted as the rest of the country, but we are growing, and we have this opportunity to get ahead of this problem before we get really overcome with mothers and babies that have major issues. The right-hand piece of this figure also shows the rate of change for synthetic opioids, particularly fentanyl, as opposed to prescribed opioids like Vicodin or OxyContin. And you can see that fentanyl has taken over in New Hampshire, West Virginia, Massachusetts. This was in the news recently with Vice President Pence almost visiting someone who was just convicted of distributing over 10,000 doses of fentanyl. So fentanyl is a big issue. California is not as impacted, but is a significant issue. Next slide. So now we're talking neonatal abstinence syndrome. And this has been the narrative for perinatal use of opioids over the years. Starting on the left, we could see the data showing that up to 2014, NAS rose more than fourfold, 433%. And it is bankrupting many state Medicaid budgets. The total bill for NAS in the country for Medicaid alone was almost $500 million in 2014. Again, that was 5 years ago. The NAS incident on the right-hand side of this graph shows in the states that were reporting to the CDC, again, northern New England, Kentucky, West Virginia, Appalachia. A lot of states weren't reporting, and one of the lessons here is this is the most recent data we have nationwide for NAS, and it's 5 years old. It is clearly worsened as the rest of the epidemic has worsened. But I'd like to change the narrative here. Next slide. What we're seeing here on the left is the rate of pregnancy-associated deaths due to drug overdoses. So previously we were talking about babies and NAS. But what we want to establish now is that mothers have been equally affected and impacted by this epidemic. What you see on the purple, on the green line or teal line is a threefold increase of all drug overdoses. And the opioid, the purple line, is a sixfold increase in Illinois of opioid-related overdose deaths. So these are maternal deaths from opioids, and this is the rise established. Now, the right-hand graph shows data that is typical of multiple states, but this is from Massachusetts, showing that the deaths that occur from opioid overdose don't occur precisely during pregnancy or in the immediate postpartum period. In fact, pregnancy establishes some protection, if you would, because of maternal interest in care. But as the intensive care provided by prenatal and immediate postpartum care wanes, that's where mothers wander and overdose deaths occur. So it's in that 42 days to a year after delivery where overdose deaths skyrocket as part of pregnancy-associated deaths, not necessarily pregnancy-related. Next slide. In that same vein, we've looked at severe maternal morbidity, major complications during labor and delivery among mothers with opioid use disorder versus all other mothers. I did this two different ways. One defining mothers with opioid use disorder as defined by ICD codes for opioid use, either in the mother or the baby, and that's the first red column on the left panel, and then on mother or baby or mother alone, and the codes are given beneath. But what these show is that mothers with opioid use disorder have 3.5 times higher rates of severe complications in pregnancy and delivery than all other mothers. This is one of the highest relative risks that we see. And so this is a high-risk group. The right-hand graphic shows the same data except restricted to severe maternal morbidity in mothers without including transfusion codes. And you get the same 3.5 times higher. So it's more than just more transfusions. It's actually a greater impact on all kinds of major complications in mothers. So we have to worry about maternal deaths, and we have to worry about major complications. Next slide. So what I'd like to emphasize is that pregnancy is a window of opportunity to identify women with opioid use disorder by screening. We're going to talk about that later. The opportunity to link these mothers to treatment and to develop a plan for optimizing her baby's care and her own care. That is the best way we have at this point of ensuring that they can stay in long-term care and actually be a mother for the baby as time goes by. Next slide. You can go ahead and next, thank you. So going to California. This is by county, and it shows you the opioid overdose deaths by county in 2017. CDPH has a wonderful dashboard that you can go in and get up-to-date data. You can drill down to county or by state is showing here. And you can see where the highest rates of overdose deaths are in the northern counties around Sacramento, and then down around the extreme southern Orange, San Diego, and then above LA at Ventura, Santa Barbara. On the right-hand side, you see the NAS incidence rates combined over several years because the rates are fairly low, and you can see a pretty significant overlap between overdose deaths and NAS rates. What's additional in this study done by the Urban Institute is the concentration of buprenorphine waivered prescribers. And you can see in the northern counties, there are some, but some are scattered. And then even less common are buprenorphine prescribers or facilities that offer pregnancy-specific services. And that's one of the goals of this project, is to increase capacity. Next slide. So as most of the audience knows, in California, we have perinatal regions, some 10, 11 regions for focusing perinatal care. And what this slide shows, again, looking at those regions, both NAS in the blue bars, the blue sidebars, and newborns affected by other drugs of addiction in the green. And the two regions that I've highlighted in red represents the North Coast, which is up all the way to the Oregon border from the Bay Area, and the Northeastern region, regional perinatal programs, and that's Sacramento up the valley again to Oregon. And those have the two highest, followed by the Central San Joaquin Valley, and then some of the southern counties at the bottom. Next slide. So the overarching goals of our combined project are to preserve the mother-baby dyad, refer the mother to treatment and keep her in treatment, reduce the incidence and the severity of NAS, i.e. the length of stay, in integration with community service. This is a project for CMQCC and CPQCC that expands our reach because it starts outside the hospital. We really need this to begin in prenatal care and potentially before even pregnancy. For screening and referral to treatment, and to start readying the mother for the plan of safe care for her and her baby after delivery. There are labor considerations, particularly anesthesia ones. And then there's, of course, neonatal considerations for how you manage the baby as it may or may not be withdrawing, and safe discharge. Next.
Thank you, Elliott, for bringing us all up to speed about the opportunity at hand nationally, as well as in California. Helen, Elliott has set the stage. Please educate us regarding addiction, and also tell us about the California initiative that's underway.
Thank you so much, Christina and Elliott. A great job of setting the stage. I want to spend a few minutes now establishing a common understanding of addiction, just a little level setting. And I want to ensure that we all have a common understanding of what we're facing when we're addressing women and their affected infants and families. Elliott spoke about a lot of national data, some of the California data as well. Just to underscore that, we've seen a fourfold increase in California as a whole in the numbers of pregnant women who have opioid use disorder during pregnancy, and a concomitant increase in neonatal abstinence syndrome. These data are from the Healthcare Cost and Utilization Project, and as we know already, California is catching up to the rest of the nation. We don't have the same level of prevalence as in many other states. However, we have the distribution that Elliott underscored earlier, and a rising increase that we want to be able to get ahead of. Next slide. So important for all of us to understand that addiction is a basic dysregulation of the critical natural reward centers and neurotransmitters that make us human. I want to drive home that this is a disease that requires treatment, not derision, and it's a chronic disorder. We also need to acknowledge that one of those critical neurotransmitters is dopamine. And when you think about it, the main things we need to survive are food, water, and dopamine. Okay, maybe oxygen in there a little bit too, but dopamine is that critical neurotransmitter that is vital to motivation in everything that we do. It helps us get up in the morning. It is a facilitator of relationships and love. It helps us with decision making. In short, it is what distinguishes us as human beings. And when we think about that, we have some very sophisticated ways now of measuring dopamine levels in the brain. Unfortunately, they're not so sophisticated that we can measure them in blood and serum, but we can, under certain circumstances, measure them in the brain. And what we know about dopamine is that the brain, on a normal day, releases about 50 nanograms per deciliter of dopamine. If we're having a bad day, you know, you're just feeling lousy, don't want to get up and get out of bed, that's maybe 40 nanograms per deciliter. Best day ever, your wedding, birth of a child, everybody's graduated from college and you won the lottery on the same day, that's about 100 nanograms per deciliter that our brains release. And in the next slide, you can see to scale what happens when we're talking about some of the drugs that are at the topic of interest today. Marijuana, alcohol are around, they stimulate a release of about 700 to 800 nanograms per deciliter. Heroin is at about 800 to 850 nanograms per deciliter. Methamphetamine, and we know that we've got a bigger problem with methamphetamine use than just about any other substance these days. The release is about 1,000 nanograms per deciliter. So here's where this dysregulation comes in. Because once the body, once the brain sees these supranormal levels of dopamine release, our bodies do what they're designed to do, and that's protect us and reorient so that they will no longer see these supranormal kinds of levels of dopamine release. That happens in a variety of different ways. We downregulate the receptors for dopamine. Sometimes our brains will actually decrease the size of the dopamine receptors. And over time, as that disease becomes more chronic, our cells, our neural cells undergo apoptosis, and the actual number of cells is declining as that apoptosis goes on. And in the next slide, you can see that the central areas of the brain that work interactively to produce and hopefully modulate activity and addiction. The key piece here is the ventral tegmental area, or the VTA. That VTA is the origin of dopaminergic cell bodies. It's important in role, in cognition, in intense emotions, in reward, motivation, and addiction. And it includes the neurons that project to prefrontal cortex and other areas of the midbrain structure. The amygdala modulates moods and fear. The nucleus accumbens is a key area for motivation. The periaqueductal gray modulates pain. And the anterior cingulate gyrus is where craving and executive function go on. And the next slide. We work a lot with case studies. That's really helpful in the medical area. And we've used KAYLA as one of our case studies. You might imagine a woman who has gone through, as a young girl, a family history of addiction, has had moderate ACEs in her life, got addicted to oral opioids after a car accident, and on top of everything has poorly controlled anxiety. So once upon a time, she got prescribed alprazolam and now has physical dependence on both opioids and benzodiazepines. She had an offense, came to the attention of corrections, but was diverted, and after diversion, went out, used again, had an overdose episode. Now she's pregnant. She doesn't have any social support, and when she gets into the hospital, because of the stigma faced by many who have addiction problems or opioid use disorder issues, she's feeling judged and feeling inadequate as a parent and totally powerless in what happens with her child and the rest of her delivery experience. So in the next slide, I want to just underscore for us the importance of medication-assisted treatment. Because when you think about addiction as a chronic disorder, you've got to recognize that the behaviors are symptoms of the disorder. The worse the behavior, moving through craving to primal activities that are just focused on getting us back to, or getting pregnant women back to a baseline level of dopamine, are not willful behaviors. They are behaviors just to survive and to have some kind of basic dopamine experience. Not getting back to the high, because they'll never do that again. And so if you consider that the behavior is a symptom, then the response is treatment. And without question now, there is no question, medication-assisted treatment is the gold standard for treatment of anyone with opioid use disorder, and particularly for women with opioid use disorder. I have to have you reset your experience of color in this slide, because one of the things that technology does sometimes is to modulate colors that you may have had in an original slide in the way they project in the webinar. And so what you see as gray on this slide really should be light green. That's really critically important, because what I want to drive home to you with this slide is that presently methadone is the medication-assisted treatment of choice for women with opioid use disorder. That is primarily because our evidence-based literature is replete with about 1,200 studies related to methadone use. Literature related to buprenorphine use is only at about 100, maybe 108 right now, but it's rapidly gaining, and most of us who have treated pregnant women with opioid use disorder will tell you that buprenorphine is fast overtaking methadone as the MAT, medication-assisted treatment of choice, for the treatment of women with opioid use disorder. Underscore here that detox and is not the desired treatment for women with opioid use disorder. Yes, it is true that there are small numbers of women who in fact will do well with withdrawal and actually be able to stay clean, be retained in treatment. However, the overwhelming majority of women, pregnant women, who undergo detoxification or withdrawal have experiences where their rate of overdose deaths, their retention in treatment, and their pregnancy outcomes are all adverse. So we really do want to move away from medication-assisted treatment as much as possible, remembering too that the vast majority of these women will go out once they are detoxed. They will go out and use again because they're trying to get back to some baseline dopamine level. Withdrawal and detoxification does not provide anything to address the absence of dopamine. And so going back out and using again puts mom and baby at risk, primarily because once women have been detoxed, they no longer have the same tolerance they had to the drugs when they were chronically using. And so if they go out and attempt to use at a dose which they experienced previously, the overwhelming likelihood is they will have an adverse outcome. Just a comment here about neonatal abstinence syndrome. Again, methadone, buprenorphine, increasingly now we're seeing studies where the severity of neonatal abstinence syndrome and the length of stays are dramatically reduced for women who've been on MAT. Buprenorphine is looking a little better than that. It wasn't at the time that I produced this slide, but a little better than methadone in that respect. And the reason why there's a green for naltrexone, which is an antagonist under neonatal abstinence syndrome, is very logical. If you think about it, with naltrexone, again, the woman is now completely off of opioids, and the naltrexone as an antagonist prevents the binding of the morphine or morphine equivalent, which protects the newborn, and the newborn does not experience neonatal abstinence syndrome. Next slide. This is our initiative on a page. Dr. Main mentioned earlier the Mother and Baby Substance Exposure Initiative. Health Management Associates, or HMA, is the grantee of a state opioid response grant from the Department of Healthcare Services. HMA actually has 5 such grants. This is the only one on perinatal substance abuse. In fact, it is the only one in the state dedicated to perinatal substance abuse. And this wonderful graphic really intends to underscore for us that we're talking about an initiative that promotes the entire continuum of care for moms, the mom-baby dyad, and transitioning into an appropriate recovery and treatment pathway after birth for both mom and the baby. Next slide. The Mom and Baby Substance Exposure Initiative is focused on outcomes that we've already touched on a bit. Our intention is to decrease the severity and the length of stay related to neonatal abstinence syndrome. We don't expect neonatal abstinence syndrome incidence to decline immediately. That's going to take a much longer period of time. In fact, it may even increase in the short term as we get more women on MAT. We also look forward to a reduced referrals to Child Protective Services or reduced withdrawal of parental rights from Child Protective Services, and initiating more women and keeping more women into treatment. Among the activities in the initiative include outreach to 10 counties that are targeted for this work, building relationships and providing support as those communities look forward to building their treatment and recovery ecosystem. We have subcontracted with CMQCC and CPQCC to bring you the quality improvement collaboratives that we're focused on now, as well as the toolkits and safety bundles. We've already curated patient-facing materials and developed other patient-facing materials in areas we think need additional support. And we'll be providing technical assistance for counties, particularly the outpatient areas of counties, as they look to enhance their treatment and recovery ecosystem. And next. I mentioned the 10 targeted counties. Here they are. You're part of the initial cohort in Northern California, but we will also be organizing the QI Collaborative and the rest of our mom and baby substance exposure initiatives in other areas of the state as well, for counties in the central part and for down in the southern part. And next. I just wanted to underscore the resources that we talked about earlier, the toolkit, the patient-facing materials, additional technical assistance resources will all be available on a new website that was launched 2 weeks ago. It's addictionfreeca.org, so there's no spaces in that, addictionfreeca.org. And this slide and the next talk about how the resources that are available. You can see there's a wonderful interactive data dashboard available, a resource library with a variety of different supports and resources, location for treatment, that's a part of the website that is growing and evolving, and a federal SAMHSA treatment locator or a connection to the SAMHSA treatment locator. Up at the top in the menu, you see California MAT Expansion Project. If you look at that part of the menu, underneath that drop-down box, you'll see Mom and Baby Substance Exposure Initiative, which is the next slide. That part of the website, as you scroll down on this particular page, which we can't do in this static slide, is where you'll find specific resources for this initiative. And I think that might be the last slide.
Thank you, Helen, so much. For our final parts of our webinar today, we are reaching out to both Drs. Main and Lee to identify emerging best practices in care. Elliott, please begin with the best practices on the maternal side.
Thank you, Christina. Like what CMQCC and CPQCC have done in prior initiatives, is that we put together a series of best practices to form a toolkit to assist quality improvement activities in our hospitals and our communities. Next slide. Because we are later to this epidemic, we have been blessed with the ability to profit from the experience of other states. So our colleagues in Illinois and in Vermont and New Hampshire, and our colleagues in AIM, the National Alliance for Innovation in Maternal Health, have been very active in this area for the last several years, and they have made many resources that we're able to draw upon. That's helped our toolkits move along much quicker than our hemorrhage and hypertension, but the concepts are the same as we've done with the others. Indeed, next slide. This week, the National Safety Bundle on obstetric care for women in opioid use disorder is now available. It's was published online and it is open for downloading from the Green Journal website, the Obstetrics and Gynecology. And this has a lot of implementation advice and great concepts that I highly recommend as a adjunct to our collaborative and our toolkit. Indeed, we actually mined this because we were involved in the production to begin with. Next slide. So the toolkit's divided into sections for prenatal care, intrapartum care, baby care, and mother care in the hospital. Starting off in prenatal care, we have 6 different topic areas, each of which can have 1 to 3 best practices around them, around education, around screening, intervention, referral to services, importantly an antenatal care plan, and then getting the mother ready for labor and delivery and baby care. Next slide. One of the critical philosophical points we want to push is that every patient needs to be screened during the prenatal period. We have seen the experience in many other states where if you screen only for risk factors such as poor adherence, poor prior adverse pregnancy outcomes, you will miss many cases, and it will add to stereotyping and focus on minority population as has been identified. This is a form of racism. Therefore, it's really essential that screening be universal. There are multiple screening tools available. We describe these. Many of these are open source. Some are minor charges. 4P, 4P plus. So this means they have 4 questions or 5 questions. Most are very easy to do and can easily be built into your routine prenatal care intake form, and it can be collected by your staff in your office. Now, everyone asks, what do you do with a positive screen? And this is where there's an opportunity for a lot of good education around principles such as screening, brief intervention, referral to treatment. We have a nice discussion of that. Motivational interviewing. How do you get moms to get interested in MAT and interested in caring for themselves and their baby? We have the leg up because of the pregnancy, but nonetheless, motivational interviewing tips are going to be very helpful here. Trauma-informed care is really an important lesson to learn about. Next slide. And this is recognizing that these mothers have been through a lot. Often they have adverse childhood experiences, or ACE. ACE is going to be a big thing in California as new laws and regulations been passed about screening every person for ACE as it impacts many adults. So conditions in childhood such as being physical abuse, mental abuse, sexual abuse, all come to bear later in life with much higher rates of substance use, much higher rates of sexual abuse, and actually pregnancy complications. So keep this in mind. There'll be educational materials around that. Next slide. We talked briefly about stigma earlier, but this is a really big deal. Pregnant women, or any woman with substance use disorder, is going to feel judged, is going to feel inadequate, and often will have a sense of powerlessness as mentioned, and these are some approaches that we need to take in simple words that are used by our staff and ourselves can make or break an intervention. So we really want to avoid treating these women as if they had some kind of terrible personality disorder and more focus on this as a disease. Next. Next slide. I mentioned that there is a clinical pathway or essentially a checklist of things to do for prenatal care. It's actually a complicated list of activities. And anytime you have a complicated or long list of activities, you need a checklist. And the checklist involves additional laboratory tests that people need to consider, additional consultations, additional other activities during prenatal care that needs to be done. So we're recommending that every woman with opioid use disorder have a checklist added to her prenatal care to make certain these get done. Next slide. The staff needs education and the patient needs education. There are wonderful materials already made by SAMHSA. Helen has talked about the fact we're collecting a lot of educational resources on our affiliated websites. And these are examples that are available and downloadable and should be available in your office as part of care. Next slide. We've worked extensively with other inpatient services for the care of the mother in the hospital. Like the outpatient arena, we need to talk about education of the staff. We need to talk about stigma and avoiding stigma. We need to talk about screening and the difference between toxicology and screen and knowledge about when to do actual laboratory testing, which is toxicology, and the additional drugs that can give false positives, and the informed consent involved. One of the very interesting things, though, that's we're working extensively with SOAP. Next slide. SOAP is the Society of Obstetrical Anesthesia and Perinatology, which is basically the lead group for OB anesthesia. They've come out with both an enhanced recovery after cesarean, or ERAS, consensus statement. ERAS is really is about any surgical procedure, and it is the way of the future to reduce the amount of opioids that are used both in the hospital and at the time of discharge. They're also finishing up an anesthesia recommendations for anesthesia management of women with opioid use disorder, and it's which is a complicated topic because we don't want to use many of our current pain medications, but some are going to be central, such as epidurals, and really the potential for prenatal education and intrapartum education on alternatives such as acupuncture TENS and nitric oxide. And anything that's available to reduce anxiety is going to be very helpful, which is why additional support and labor is going to be good. Next slide, moving on toward the plan of safe care. We've had for more than a decade, plan of safe care for the baby. In fact, it's a state law in California and in most states that you have to have a plan of safe care for the baby. We feel it's equally important that you have a plan of safe care for the mother. What that means is that you have thought through how you're going to hand off the care from the delivery facility to ongoing care in the outpatient arena. And that means both for MAT, for behavioral health, for early return to see the obstetrician or the obstetric provider, and any other key support services in the community. So we're looking not just telling them to set up an appointment, but you want to have warm handoffs back so that the providers know what happened in the hospital, what's going on in the woman's life, and then that's going to make the ability to have continuity of care be completed. And remember that the postpartum period, particularly late postpartum, is the time of greatest risk for the mothers with opioid use disorder. Next slide. I want to emphasize that the importance of relationships with community organizations that are working in this area. Most of our counties have a number of these. This collaborative is focused on reaching out and trying to establish connections between prenatal and hospital and community organizations. And this is not only community support services, but actually public health agencies, WIC, and in particular, Child Protective Services, as we want them to become engaged and knowledgeable about our efforts for plan of safe care for both mother and baby. And we think that will help reduce the anxiety and the fear of having the baby removed, which in turn will improve the access and acceptance of prenatal care with this patient population. So I'm going to go ahead and turn this back to Helen, or to Henry, excuse me.
That's right. Thank you so much, Elliott. Henry, we're looking forward to hearing about the newborn best practices.
Thanks, Christina, Elliott. Yeah, and one thing to highlight again is that the best practices for the baby really involves caring for the mother-infant dyad together, which is nicely illustrated in this slide. And this is the draft toolkit content for the neonatal section, and I'll be giving a brief summary of these issues in the next few minutes. And we're considering, again, emerging best practices. We're learning from experts and researchers in the field, but also looking forward to learning from the hospitals in California, the programs that are already working on these issues. And we plan to continue to update the toolkit and give resources accordingly. Next slide. So this is going back to the identification, evaluation, and treatment, that when we talk about and discuss these cases with our team, that we want to use appropriate language. And this is a resource, a snapshot from the National Perinatal Organization, and really follows what Elliott talked about, encouraging providers to have positive interactions with both families and staff, to have supportive and non-judgmental interactions, because ultimately we know that supporting these families, including supporting the mother to breastfeed if appropriate, and bonding with the baby, will ultimately lead to better outcomes for both the mother and the baby. Next slide. We've heard about the importance of maternal screening, and each hospital will benefit also from developing selective newborn screening policies. And it's important to note that current tests for newborns are susceptible to both false positive and false negative tests. So relying on these toxicology tests for newborns as well, including potentially having a universal screening approach, may not be appropriate, as it may lead to both missed cases and potentially false positive tests that may not actually help with management. So ultimately, as quoted here at the bottom, a detailed, professionally obtained history is more helpful than toxicology screening of the newborn to accurately screen for substance abuse. And these guidelines from Vermont that are referenced here are one potential useful resource for those institutions seeking to develop a local policy. Go to the next slide. So this notion of a therapeutic relationship with parents has been highlighted by the work of the group at Yale, led by Matthew Grossman. And I'll note that this quality improvement project that they embarked on took place over a number of years, from 2008 to 2016. And in their progression of quality improvement cycles, they implemented programs of standardized non-pharmacologic care, prenatal counseling, transferring care from the nursery to their inpatient unit, changing their assessment strategy, which I'll discuss more in a little bit, and rapid morphine weans when it's used, giving empowering message to parents and spreading this change to the NICU. And with this approach, they were able to reduce their length of stay from 22.4 to 5.9 days. They also reduced the neonates treated with morphine from 98% to 14%. Next slide. And this is a quote from their paper on the inpatient unit. We explained that our first line and most important treatment would center around measures to comfort the infant and that these should be performed by a family member. Parents were told that they were the treatment of their infants and must be present as much as possible. Nurses and physicians focused on supporting and coaching parents on the care of their infants. Next slide. Dr. Elisa Walkman and her group in Boston led another QI project, which took place over a year in their large urban center with a large number of opioid-exposed neonates, over 100 annually. And just to emphasize this strategy, what we're calling non-pharmacologic care doesn't mean just not give drugs. It really does mean an effort to care for the mother and infant using strategies listed here, such as encouraging parental presence, skin-to-skin, holding, breastfeeding, and providing a calm, low stimulation environment for the family, which often means probably not placing the baby in the NICU if possible. Next slide. And one of the principles of this approach of both the Yale group and this group in Boston was to transition from assessment using the Finnegan score, which has been a traditional tool in the NICU for this purpose, to a somewhat simpler and functional scale of what's called eat, sleep, and console. And in this assessment, if the neonate can effectively eat, sleep, and be consoled, then things are going well enough to continue to current care, which in many cases may mean to not necessarily treat with drugs. Part of this strategy did involve increasing their cuddler program for families who are not always able to be present. And with this approach, you can see their results. They're able to reduce the number of neonates treated with drugs as well as second-line agents, reduce the length of stay, and sorry, that should be 17 to 11 days, and then also increase parental presence at the bedside. Next slide. And then for those babies who may require pharmacologic therapy, there's continues to be studies done on this topic, and I don't think I have the best answer for every institution, but one strategy that's been advocated and studied is moving from a scheduled morphine dosing to a PRN dosing regimen. Instead of starting drugs on a scheduled basis for every infant who might have some symptoms, is to minimize the therapy by starting PRN. And secondly, to develop protocols for weaning when drugs like morphine are used, and not rely on whoever the provider is on that particular day to make decisions arbitrarily. Next slide. Again, there's some emerging potential evidence, and this may or may not be the right one for every institution, but methadone has been studied compared to morphine, and there's some growing evidence that it may be preferable. And in this one study, they reduced their length of stay from 21 to 14 days using methadone versus morphine. Next slide. Yeah, and just to wrap up, we again want to emphasize that the cornerstone of any of these strategies is to support the mother-infant dyad. The mother's care needs to be supported both in the hospital and at discharge. And therefore, we are hoping to grow the partnerships that exist between the hospital and post-discharge care, as well as community resources, including the medical providers for the baby, being aware of the mother's needs and being aware of resources that the mother can be referred to for support for their recovery, which will ultimately lead to better outcomes for both the mother and the baby. So I think I'll wrap up there. Thanks, Christina.
Thank you so much, Henry. That's a wonderful last thought. Nearing the end of our time together today, please support our efforts at quality programming by filling out the evaluation you will receive tomorrow. Valerie Cape, our program manager at CMQCC, is coordinating our questions. Valerie, we're running low on time today. Do you think there's a question perhaps or two that would benefit the audience with one of our speakers?
We haven't seen any questions come in. There was inquiries about the slides being posted, so I have answered those, that they will be available to the participants. And there were just a couple of comments about things in the slides, so they're excited to get the new slides.
Wonderful.
There is one question that's come in. Not a question, but a comment. I like the idea about not screening all babies, but CPS wants it. Anyone want to comment about that?
Helen, would you mind taking that one?
Sure, I'd be happy to do that. The current requirement is for an assessment of neonates if there is evidence of neonatal abstinence syndrome. There is not a requirement for a urine toxicology screen, and that assessment is to be done by ideally a physician involved, a medical social worker, and other necessary hospital staff to make a determination of whether or not a Child Protective Services report needs to be made. The all-county letters related to this area are in revision, but the plan of safe care actually requires a contact with Child Protective Services so that they are at least aware of a high-risk infant, regardless of whether or not parental rights are terminated.
Helen?
This is Elliott.
Yeah.
Just to add to that, what we're learning is that there seems to be considerable variation among counties in
Yes.
terms of CPS policies or actions, and that's one of the areas that we hope to work on in this statewide collaborative, working with some of the most impacted states as we outlined earlier. So that's an opportunity for improvement that we envision is to how to move CPS and hospital interactions into a better spot and more reflective of these activities and other current activities. So stay tuned on that. I think there's a lot of work that can be done.
So we've had about a half a dozen questions come in. Does MAT raise dopamine levels?
Good Helen question.
Great question. Great question. So the use of methadone and buprenorphine, whether it's buprenorphine mono or the combination therapy, they're both partial agonists. So yes, they do provide a baseline dopamine level. Naltrexone, of course, is an antagonist. So there is no dopamine released by an antagonist. No dopamine stabilization from naltrexone, only from methadone and buprenorphine.
Okay. Have there been any studies on withdrawal when using Suboxone?
Yeah, great question. So there's a bit of a controversy right now about whether or not the mono, any women who maybe were on MAT with the combination product should be transferred to the mono product. I think what we're learning in the literature is it really doesn't matter, but for the time being, the standard of care is to either keep or transition women onto the mono product.
Okay.
So, Valerie, I want to thank everybody today. Thank you for joining us and our speakers. And as a reminder, the webinar is available on CMQCC YouTube channel. Thank you for joining us today.
Thank you.